next up is Suzie Allen. She is the Oncology Clinical Nurse Specialist for Winship Cancer Institute of Emory Healthcare. Dr. Allen is the chair of the Emory Nurse Legislative Council, the interim chair of the Ambulatory Research and Evidence-Based Practice Council, and the president of Georgia CNS Association. She has over 34 years experience in oncology. Dr. Allen, the floor is yours. You have 25 minutes, and when my face pops back up, that's your sign for 5 minutes to wrap up and take questions.
All right, thank you. So good afternoon, everyone. Let me pull my PowerPoint. Okay, I hope everyone can see my PowerPoint.
Yes, ma'am, it is up. It's beautiful.
Thank you. Okay, so as you said, I'm Suzie Allen, and I'm going to tell you about, this was my DMP project called Introducing Antiseptic Barrier Caps to Outpatient Oncology Nurses. So oncology patients use over 5 million central lines a year. However, it increases their risk for complications such as central line associated bloodstream infections, or CLABSI. In the US, oncology patients develop 250 to 400,000 CLABSI per year, with an attributable cost of $48,000 per episode. Patients with hematological cancers are at even higher risk for developing CLABSI. This results in prolonged hospital stays, increased costs, morbidity, or mortality rate of 12 to 40%, and lack of third-party payer reimbursement. CLABSI is a reportable hospital-acquired condition due to the inpatient fiscal accountability, but is preventable by using evidence-based practice, such as a central line maintenance bundle. And an antiseptic barrier cap is a crucial part of the maintenance bundle. So the swab cap, as you can see here, the little orange cap, is an antiseptic barrier cap, which covers the needleless connector hub and provides physical and chemical barriers through passive disinfection with 70% isopropyl alcohol for 7 days, if that cap is not removed. It is used exclusively inpatient, which leaves my outpatient oncology patients with central lines vulnerable outside the hospital environment. So in 2017, the nurses in our bone marrow transplant clinic requested to use the swab cap. So our BMT patients, they have to manage their own central lines at home, such as changing their own dressings and flushing their lines. The request was declined by our nursing leadership, citing excessive cost and low efficacy as barriers. But we found that the cap only costs 25 cents each, and then through the literature search, it provides continual disinfection for that 7 days. So the only outpatient data collection is through the BMT or bone marrow transplant accreditation program, where the inpatient outpatient central line infection rate exceeded 100 over a 1-year period. And that's a huge number. This supports the need to add an antiseptic barrier cap to the outpatient central line maintenance bundle. So our critical question was, will an educational intervention and trial on utilizing an antiseptic barrier cap in the adult outpatient setting increase the knowledge, confidence, and product usability in oncology nurses? So let's look at the literature review. So I found 12 articles that supported my project, and then I divided them into different themes of connector hub decontamination, outpatient oncology population, inpatient use, and systematic reviews. So 4 studies examined a contaminated needleless connector hub and evaluated the use of an antiseptic barrier cap versus an alcohol wipe for microorganism kill rates. 2 studies were in vitro in a regulated lab environment with control groups. The other 2 were in vivo studies and cultured the caps after they were used for patient care on an all adult PICC line patients in one hospital, and then also an outpatient oncology day unit. So all 4 showed statistical significance to prevent that intraluminal contamination using an antiseptic barrier cap. So one crossed over, as mentioned on the previous slide, connector hubs were studied on central lines of outpatient oncology patients. And then we also had an ambulatory home health company that used these caps on 280 TPN patients and reduced their CLABSI rates from a mean of 1.36 to 0.47 with a p-value of less than 0.001. So 2 professional nursing organizations, the Oncology Nursing Society and the Infusion Nursing Society, recommend using this cap without stipulating any specific practice setting. So the antiseptic barrier cap has been studied extensively for inpatient use in various patient populations. A randomized control trial in cardiology patients compared the cap to just a dead end cap. The outcome was 1 CLABSI in the intervention group compared to 14 in the control group. Another study tested all patients with peripheral and central lines to evaluate that cap's use, looking at CLABSI rates and cost after 12 months. The outcome was a 40% infection reduction, and they saved $300,000. Another inpatient study cultured all PICC line connector hubs on an adult inpatient oncology floor after using the antiseptic barrier cap. After 6 months, the CLABSI rate was only 1 post-intervention compared to 16 pre-intervention. And then I found 2 systematic reviews. One examined the disinfection practices in over 170 studies and abstracts and found a 48 to 86% CLABSI reduction when using an antiseptic barrier cap. The other review included meta-analysis, assessed the cap versus an alcohol swab. The incidence rate ratio of 0.59 with a p-value of less than 0.001 showed that the cap is effective in reducing CLABSI rates and should be added to that central line maintenance bundle. So let's take a look at the methodology section. So my project was approved by the Georgia State University IRB and then also by the Protocol Review and Monitoring Committee at my project site because of its NCI designation. Informed consent was completed on each subject with voluntary participation. And then I used alphanumeric identifiers for each subject to maintain their anonymity. The project is quality improvement with a pre-test, post-test study design, and we utilize the PDSA QI framework. Setting is an infusion center in an academic medical center within the Southeast US. 20 outpatient infusion nurses were recruited using non-random convenient sampling, and the project was implemented over a 14-week timeline. So I created a demographic survey which had 10 questions inquiring of the nurse's role and gender, their nursing oncology experience, central line use, and in any prior antiseptic barrier cap use. It also asked several questions concerning CLABSI prevention, risk, and cost. I created an educational module that met 4 different objectives: define CLABSI and central line complications, identify the significance of the cap, interpret the evidence for using the cap, and describe and apply an antiseptic barrier cap. And then I also included swab cap education and cost analysis. The pretest and post-test contain the same 10 questions that were created from those 4 objectives. They assess the antiseptic barrier cap and central line infection knowledge. So the system usability scale is a 10-question, 5-point Likert scale, and it was used to assess swab cap ease of use and nursing confidence after the product trial. It's broadly accepted for usability calculations, and you can find it in over 1,200 journal articles. It's a valid, reliable tool, Cronbach's Alpha 0.90, and it has its own calculator for analysis. And it also has a key that benchmarks the results against a standardized reference guide. And then the score gives us 4 different measurement variables, and anything above 68 is considered above average. So for analysis, I use version 28 SPSS. I use frequency table to describe the subjects, and I'll show you a few of those. The Wilcoxon signed rank test determined the knowledge change from that pre-test to post-test. And then again, that system usability scale data used its own calculator. And there are some of the variables that you could divide it into. So let's look at results. So all 20 of my nursing subjects completed each project intervention. So this is just a bar graph that shows some of the nursing subjects' demographics. They were, of course, predominantly female and registered nurses. Nursing experience varied a little bit, with 55% having less than 10 years, while 85% of the nurses had less than 10 years of oncology experience. So for the Wilcoxon rank test, to evaluate that pre and post-test scores, so the difference between the pre and post-test mean was statistically significant. The pre-test data ranged from 10 to 80 with a mean of 55.5. Post-test scores range from 50 to 100 with a mean of 86. So central line infection and antiseptic barrier cap knowledge levels were substantially greater after the subjects received the education PowerPoint than before the education, with a p-value of 0.007. So the individual SUS or system usability scale scores range from 65 to 100, with a mean of 87. So that overall score of 87 for the swab cap ease of use ranks as acceptable with an A for grade and an excellent rating. For the project question concerning whether the nurses felt confident using the swab cap, 100% or all 20 reported confidence, with a breakdown of 85% strongly agreeing and then 15% agreeing. So what do our results mean? So the project answered the clinical question, with the results showing an increase or positive finding in each question variable. The outcome suggests administering education module and product use can increase nursing confidence and knowledge. But nursing is skeptical unless a product shows value by increased quality and is fiscally sound, which most of the subjects having less than 10 years of experience, they grew up adapting to novel tech advances, and they're more likely to accept and promote this antiseptic barrier cap. Product cost was an initial barrier, but we found the cap cost only 25 cents each compared to the $48,000 per CLABSI incident. Another barrier was product efficacy. The literature reports CLABSI reduction by an antiseptic barrier cap of 40 to 80%. And then that cap bathes that connector hub continuously with the 70% isopropyl alcohol for 7 days. So when assessing the cost-benefit comparison, I did a table for you to be able to look at it a little easier. CLABSI has an attributable cost of $48,000 per incident. So 100 CLABSIs would cost the healthcare system $4.8 million per year. An equivalent swab cap cost for those 100 patients over 1 year is only $7,800. And that's overestimating using the cap at 3 clinic visits per week with 2 caps for each line. So this potential cost savings of $4.79 million per year to the system, the patient, and third-party payers. So there's several limitations noted during this project. It was conducted at a single outpatient oncology infusion center with only 20 nurses, small sample size. It was also conducted during the pandemic with nursing shortages and a high number of part-time staff, which required multiple visits for recruitment and completion. And then the swab cap trial was shortened along with the number of caps each nurse received to use due to project site regulatory requirements. So CLABSI continues to be a major issue within the oncology patient population. Educating nurses is essential to improve patient quality and safety. Sorry about that. So this project allowed me to promote change within my specialty and patient population of oncology using evidence-based practice found through the literature review. It fostered that clinical problem-solving environment in outpatient oncology nursing by encouraging the nurses to actually discuss central line infections in the outpatient setting. And then it promoted fiscal accountability by reducing those healthcare expenditures at the system level. And the experiential learning of the nurses actually being able to use and manipulate the caps in actual practice supports their professional development. So in conclusion, we encounter obstacles when trying to increase patient outcomes and reduce healthcare expenditures across the care continuum. QI projects can certainly make a definitive change, increasing the likelihood of saving lives and improving care. CLABSI incurs the most significant expense of any healthcare acquired condition, but outpatient measurement and the use of an antiseptic barrier cap as evidence-based practice intervention lags behind. With infusion center nurses reporting high levels of knowledge, confidence, and ease of use, along with the evidence showing that low cost and the CLABSI reduction, and then that 7-day product use window, hopefully all barriers can be removed from adoption of the caps in outpatient oncology nursing. And this QR code contains my references. And thank you very much for listening to my presentation. And are there any questions?
And you finished a tad early as well. You had about 8 more minutes for your presentations. We have plenty of time for questions. I'm going to laugh and say the cost savings, that seems to be a no-brainer. Even though it was a small size, I'm like, wow. And yet you were denied initially because of cost.
Yes. Yes,
what?
yes. So we actually had, and this just goes to show you how, I guess, powerful some people can be in, small settings. It was actually one manager who ran the infusion center, and she just said, no, we're not using those. And so everyone else just kind of dropped it. It was pretty amazing. Yeah, so hopefully it took this, this whole project to hopefully bring about change.
Have you showed her your results?
She actually retired, which is probably a good thing.
Yeah, sounds like maybe she needed to, because that's that in nursing, I guess, and probably in many professions, we're good at saying, but we always did it that way. No,
Yes.
don't change anything. We've always done it that way. I hate that answer. No, it's not how we work here. Evidence-based practice, there's the reason for it, and you just proved it.
Yes, thank you very much.
That was good. And your Wilcox-Son rank test. Tell me a little about that. I'm looking to do a project with a comparison t-test, but I don't remember the Wilcox-Son. Can you give me a little bit of info?
So the Wilcox-Son rank test is the non-parametric partner to the t-test.
Okay.
Yeah. So you have to have that that ordinal measurement. If you have categorical measurement, then you would use the t-test, I believe. And I believe that this is the non-parametric, where you have only, a certain number of options. Like I only had, like 1 to 4 that they could choose. Yeah. So it's just the non-parametric partner to it.
It's definitely something I'm going to do a little more reading on and look up and see if it's something I can add, because mine is an educational study as well.
it was really easy. We had a statistician that
Mhm.
helped us, yeah, to run the data. If you have one, let them run your data for you.
Say, praise God, I've got a math guy
Yes, yes,
from the
that's
university, and he's agreed to jump on board. And I'm like, sweet, because I don't want to go back and learn all that again.
yes. Once I figured out how to do it, it was very easy to to run the numbers, but it takes a little input. I had to manually input some stuff into SPSS.
Right, absolutely. Anyone else have questions for Suzie? I see lots of faces on here. I don't see anything in the chat. No raised hands. Any thoughts, any input? They're all so
So,
quiet.
I will add, I actually just recently was able to present it throughout my system, my outpatient area.
Nice.
And so they recommended that I present it at our system,
Mhm.
at the system level, to get a recommendation. They just want like okay, we should go and use it. But I'm hoping I can get that and we can start using them in the outpatient area.
I would hope so too. So through your study, the nurses for outpatient are who gave them to the patients versus
Yes.
the patients having to order them and have them at home.
Yes, yes. And I would add another that I didn't put on here. Patients actually, they're used inpatient all the time. And the
Mhm.
inpatient nurses stress to the patients how important it is to use them to prevent infection. And then they come over in the outpatient area and we don't have them. We do not offer them. So it's embarrassing that we can't offer that to our patients as a safety mechanism. So they go out and buy their own and they will bring them in and ask, yes, in some of our areas and, individual cases, and get the nurses to put them on for them after they use their lines.
Oh, that's funny. I would be one of those patients that would have done the research and been like, oh no, I'll buy my own, thanks.
Yeah, and they do. They buy them Amazon, eBay, wherever, yeah, they can find them.
Wow, interesting. So yeah, hopefully this is going to promote a change. I remember using some of those with the central line dressings when I taught med surge, and they had
Yes.
the anti.
Yeah, put the cap on the end of it. Yes.
Mhm.
Yes.
Oh, and here I would have thought, because that was a few years back, that it would have become more standard practice if it were truly helpful, especially with those central lines and PIC lines and all that direct access.
Well, it is inpatient because that's where they've studied it,
Yeah.
because that's where they lose money.
It wasn't
They lose
outpatient.
money for the inpatient. If patients develop a CLABSI inpatient, the hospital loses money for that. So that's the only place that they've really done all the research on it.
Wow. Wow. Just doesn't, to me, it just seems like a no brainer. If you're using them
That's
there, why wouldn't you use them when they take that stuff home? Come on.
exactly, yes, provided across the continuum of care. Exactly.
Mhm. But hey, who are we?
Exactly.
All right. Well, anyone else have any input, any questions, anything else you want